Hi, my name is Kip Ludwig. I'm an associate professor at the University of Wisconsin-Madison. I'm also the co-director of the Wisconsin Institute of Translational Neural Engineering, and I'm here today to talk to you a little bit about invasive and non-invasive stimulation of the vagus nerve. These are my disclosures. You'll see I actually have several conflicts in this space, and I can honestly say I'm probably maximally conflicted. I actually have co-founded companies that both do invasive and non-invasive stimulation, so I really either have a lot of horses in this race or not a lot of horses in this race. So some important definitions for this talk. In the upper left-hand corner is our definition of invasive vagus nerve stimulation, or IVNS, in which case an epidural cuff is surgically implanted onto the cervical vagus. In the center is transcutaneous vagus nerve stimulation, where the electrodes are placed on the skin but are attempting to focus on the cervical vagus trunk. And on the lower right is auricular vagus stimulation, where electrodes are placed near in the ear at the semiconcha or tragus, where there are superficial sensory receptors that then go to the auricular branch of the vagus nerve. When I was first asked to talk about this, I was actually asked to participate in a debate of invasive versus non-invasive vagus nerve stimulation. And not a lot of people wanted to participate in a debate, including myself. I don't believe this should be set up as a debate. I believe that invasive and non-invasive each has their strengths and weaknesses, and that we have a lot to learn from each other as well. That being said, I do know there are people who do implanted vagus nerve stimulators who are skeptical that non-invasive stimulation is activating the fibers of the cervical vagus trunk, that's 2 to 4 centimeters away from the skin. And there are people who are on the non-invasive side who have stated publicly it's not only activating those deep fibers, it's activating them better than an implant as well. So I will discuss some of the basics of neural interfaces that are common to both that I think we need to discuss to have this conversation. I'm going to talk a lot about newer developments in invasive vagus nerve stimulation that I believe have implications for non-invasive as well. Then I'm going to directly talk about the evidence to support and refute transcutaneous cervical vagus nerve stimulation is activating directly the fibers within the cervical vagus trunk in the neck. Then I'm going to talk about auricular vagus nerve stimulation. And then finally, I'm going to try to address the commonalities. I think there's a lot we can learn from each other, and I think there's a lot of lessons from each that are important to disseminate. And finally, I'm going to end on a positive note. Importantly, I do think, in theory, IVNS, TCVNS, and TAVNS should be different than each other, but they actually aren't very different right now when you look at the phenomenological data. I think that's because everything we're doing for all of them is actually pretty crude and does not mimic natural sensory traffic, and we're going to see more differentiation and more strengths and weaknesses as we start to understand exactly what we're stimulating. I also want to point out I'm one of the few in the field who's a jack of all trades. I do non-invasive and invasive. I also follow all the literature across all the indications. So I have a lot of breadth and I can make some connections, but I don't have a ton of depth. There may be some important studies I'm missing that may change some of my central theses or thesi, whatever that is. Let's discuss it. The most important thing is I think we should all be talking, and I'm hoping this can start a conversation. So to start, some key basics of neural interfaces. So this is a cartoon I made a long time ago to illustrate how stimulating tissue is a little bit different than just resistors and capacitors. A lot of people think about applying current and injecting current, when in reality we have to change from a wire which has electrons as its mobile carrier to ions as our mobile carrier. So if we have our nerve that has a resting potential of about minus 70 millivolts, when we apply electrons to an electrode, what we're really doing is drawing mobile charge carriers, or in this case, predominantly ions, near the electrode, towards the electrode to balance that charge. Now, in reality, you just saw a bunch of positive ions move from a distance to go to that electrode. What happens really is positive ions near the electrode move to it, then positive ions that are a little bit further away move to replace where those were, and so on and so forth. But this actually then ultimately propagates to the nerve and creates a difference in that resting potential. So in this particular case, we saw a lot of positive ions move towards the cathode, and so we may have started with a minus 70 millivolt difference at the lipid bilayer for the nerve, but now because we've pulled some positive ions away and we've moved some positive ions internally, we're at a minus 55 millivolt difference. That's enough to cause an action potential nearby the nerve. These distance nerves actually just get potentiated. They get slightly a change in the resting potential, but they don't actually get driven to the point of causing an action potential. So why this is important in terms of non-invasive stimulation or stimulating anything at a distance is you should be thinking of electrodes more as a sink that's drawing ions away from the nerve. And in reality, this makes it very hard to control what you're activating at a distance because you're drawing it from a 3D space. These basic principles make it actually very hard to compare different electrodes and different geometries. We often think in terms of current applied. We used to think in terms of voltage applied, but that's actually not what activates the nerve. What actually activates the nerve is what's called the activation function, which is the second order spatial derivative of the voltage across the lipid bilayer it seems. And this is actually not as related to the current applied, but to the charge density applied. This is a common concept in cardiac pacemaking, where we know if we apply the same current through a large electrode, it actually is pretty diffuse, and that's kind of what you're seeing on the right, and may not activate. You have to apply much more current to activate. If we apply it through a small electrode, we create much more stronger local ion concentration changes, and you activate at a much lower threshold, even though in both cases you're given the same current. Another really important concept, especially if you think of it like an electrical engineer, is that current flows from cathode to anode. And whether we're doing transcutaneous or even invasive vagus nerve stimulation, we're trying to stimulate fibers at a distance from our cathode and anode pair. And so what we're trying to do is get the current to go to the fibers within the fascicles while minimizing the current shunting from cathode to anode. So what does this really mean? For non-invasive, this is a really interesting concept. In that if we move our cathode and anode closer to each other, we actually short more current between cathode and anode, and we get less of depth of penetration. When you look at some non-invasive stimulation designs, the cathode-anode separation is actually very little, and they should get very little depth of penetration. This is actually also an important feature for the gamma core device, because they do something that's really interesting. They apply bursts of 5 kilohertz. And the reason they're applying bursts of 5 kilohertz at 25 hertz is because the impedance of the skin is actually much lower at 5 kilohertz. So the hope is that they actually prevent some of the shunting from cathode to anode and get more depth of penetration into the tissue non-invasively as well. So this creates a lot of important points. One is that the fall off of an electric field from an electrode is actually really steep. It's 1 over R, where R is the distance from the electrode if you're doing it in monopolar configuration. Depending on your spacing, if you're doing a bipolar or dipole configuration, it's 1 over R squared. What that functionally means is if it took 1 milliamp to activate a neuron at 100 microns, at 200 microns, it's 4 milliamps. At 400 microns, it's 16 milliamps. The other thing is charge density matters. A lot of our reporting doesn't give us the charge density and spacing, and the orientation of the cathode anode actually matters. So there's a nice study by Woodbury that compares the activation thresholds of B fibers in the vagus in rats compared to humans. They use the same pulse width and frequency. And what they found is that it took about 25 times more current to activate B fibers in humans or in large animal models. And this is because even if you have an epineural cuff, you're at very different distances to the underlying fibers in a rat versus humans, and also because they're using smaller electrodes, the charge density changes a lot. So the other thing that derives from these basic principles is there's an order of activation of different fiber types. And specifically, and this has to do with the interaxonal resistance, we activate large diameter fibers before we activate small diameter fibers. And different diameter fibers actually correlates to different groupings of function. So for vagus nerve stimulation, the vagus has A alphas through C fibers, large diameter motor fibers in it that innervate things like the cricothyroid muscle. It also has A deltas and C fibers, which tend to come from mechanoreceptors from the visceral organs, and it has parasympathetic B fibers, the efferent fibers going to the heart, or the lungs, or the gut. So we already have a problem in invasive vagus nerve stimulation. And that's when we first start stimulating at the lowest levels, we start activating A alpha large diameter fibers that activate the neck muscles, and then A beta fibers, which are typically sensory fibers from the same neck muscle motor spindles. We want to get to A deltas and B fibers. A deltas is essentially encoding sensory functions from the end organs, the afferent pathway that goes to NTS, which we'll talk about, or B fibers going to the heart. There was a misconception that we were stimulating C fibers in the middle 2000s. That's actually been debunked. You actually have to crank up so much current to stimulate C fibers. It's very unlikely clinically that we're activating C fibers at all. So this is a great study by Yu and Grill that illustrates several of these points, actually. So in the upper right-hand corner, you see the histology of a canine vagus, which typically has one fascicle and a thick epineurium. And they did epineural cuff stimulation, but then epineural cuff recordings. So those types of recordings that you see, what are called evoked compound action potentials, or ECAPs, are in the top up here. And at the bottom, you're seeing both the recordings and then the stimulation thresholds. So in the lower left-hand corner, it's really interesting. They actually did recordings when they removed the epineurium and placed the recording electrodes directly on the fascicles versus on the epineurium. And this shows you the attenuation of the recorded ECAP signal. And in fact, the other interesting thing is A fibers, these large diameter fibers, create a much larger extracellular signal. When you start getting to B and C fibers, they become really hard to record. And then when they could really only record from them when they started removing the epineurium and putting the electrode directly on the fascicle. The same thing is in terms of in the middle bottom in A, the amount of current they needed to activate each fiber type. The very fast A fibers was typically in the hundreds of microamps. The slow A fibers and B fibers, I've talked to Warren, and this fast B and slow B really should be slow A and B fibers, are somewhere in the 2 to 4 milliamp range. And then to get C fibers, they had to get somewhere around 17 milliamps. And this is something we see very consistently. The largest diameter motor fibers, the threshold to activate is typically 1/5 of what we need to activate A deltas and B fibers, which overlap in their thresholds. And then for C fibers, we need another 5 to 10x to activate those as well. So now I'm going to talk a fair bit about the history of invasive vagus nerve stimulation, the theories of how it works for different types of therapies, and a lot about recent results that show that the dosing of invasive vagus nerve stimulation is quite complicated. So this is the NIH SPARC meeting, so presumably everybody knows the basics here. But in general, the vagus nerve efferent pathways, the parasympathetic efferents, go to most of the visceral organs. Similarly, we have afferent communication to the brainstem through a way station called NTS, the nucleus of the solitary tract, that then engages both the sympathetic parasympathetic system, but for things like epilepsy or for stroke rehab, also engages most of the neurochemical centers in the brain that project to cortex, whether they provide norepinephrine, serotonin, dopamine, or acetylcholine. This means you can create what a friend of mine at Mayo used to call a bioplausible bullshit explanation that vagus nerve stimulation can cure everything. That doesn't mean it does. It may or may not, but you can at least make a connection. So in the earliest vagus nerve stimulation work to treat seizures, they had seen that you have these large muscle contractions and seizures, and had thought perhaps stimulating the vagus afferents would inhibit the motor activity output. A little bit later, they started to realize that you may be activating or creating GABA within the brain, which is a primary inhibitory neurotransmitter, and maybe that's how we're impacting seizures. There's a nice study by Zabara in 1992 where they showed that vagus nerve stimulation could abort injected induced seizures in canines, and importantly, the effect maintained after caudal transection. This means that the afferents to the brain are activated for the effect, not the parasympathetic efferents. Note the mechanisms for vagus nerve stimulation for epilepsy are actually still highly debated. So there have actually only been, that I'm aware of, 5 blinded clinical studies that included a quote-unquote sham. Now we have a difficulty with creating a sham in vagus nerve stimulation because typically you can feel both. So what are considered sham-controlled trials are typically something with a high dose and something with a very low dose you don't expect to have effect. And what you see when you look at least for seizures, across the 5 studies that have done this, versus the controls or the low arm in this particular case. The seizure reduction, although it is there, in this case it's 24.5% versus 6.1% reduction in seizure from baseline, it's not fantastic. And so we often then stratify into responders and non-responders. And you'll hear a lot of people say 50% of the VNS patients get a 50% reduction in seizure frequency. In reality, though, a lot of that data is post hoc. We're no longer double-blinded, and so there's probably some truth to that. But if you look at the blinded data, the data is a bit more modest, and you often see a fairly substantial effect in the low arm as well. So importantly, in heart failure, and even if you're getting to stroke plasticity or the inflammatory reflex, the pathways hypothesized are very different for therapeutic effect. At multiple places in the body, we have what are called baroreceptors. They're located in the heart, in the aortic arch, and in the carotid sinuses. And these are mechanoreceptors that sense distension of the artery due to blood flow. This then creates, through voltage-gated channels, a signal that propagates through the vagus and through the carotid sinus nerve to the glossopharyngeal. And as the artery pulses, what you see in the lower right-hand corner is these baroreceptors will actually pulse with the artery. They sense the distension of the tissue. What's important to note is they do not fire continuously. Type 1 and type 2 baroreceptors pulse with each heartbeat. And depending upon the type, they might start at 2 hertz and go to 20 hertz. They might start at 20 hertz and go to 40 hertz when they're called loaded and unloaded. So I'm going to start with the most simple pathway, which is actually the baroreceptor activation of the carotid sinus. And that's simply because those fibers go to the carotid sinus nerve and the glossopharyngeal. They don't have as many other fibers that do different things as the vagus does. But these fibers do project to NTS and do change sympathetic tone. In fact, specifically, the baroreceptors in general will go through the vagus and carotid sinus nerve, go to the nucleus of the solitary tract in the medulla. It'll inhibit the caudal ventrolateral medulla and activate the dorsal motor nucleus of the vagus. This causes central sympathetic inhibition and parasympathetic excitation. And in general, we then get decreases in blood pressure and decreases in heart rate. Now, even when you're stimulating the carotid sinus bulb to get the baroreceptors, you're actually stimulating in a very non-natural fashion at one point in a system when there's multiple different baroreceptor beds giving input to NTS as well. So a reasonable question is, when these baroreceptors pulse, and there's many of them that we're not intervening with, can we stimulate continuously at one baroreceptor bed and change sympathetic parasympathetic tone? And so this is a case where you're seeing in chronic animals, in the bottom is just acutely, that we can stimulate continuously at 20 hertz and at 75 hertz. And what you'll see is a drop in blood pressure that when we stop stimulating, it comes back up. If we stimulate at higher frequencies, it tended to dip and then recover a little bit and then come back. And then in this upper right-hand corner is actually stimulating over a cohort, 2 different cohorts of 8 dogs, for a week. So these are 3 days unstimulated, this is the stimulation period, and then 3 days unstimulated. And this is pretty repeatable. So this to some extent is surprising in and of itself, that these are healthy animals, that the system doesn't immediately through the other nodes adapt. And the fact that we're stimulating non-naturally continuously at 20 hertz or 75 hertz, when that's not how these baroreceptors function, is also a really interesting fact. So unfortunately for the vagus nerve, the situation is a fair bit more complicated. There's beautiful work by Jeff Ardell where he stimulated at different doses, showed what the cardiac response was, but then also did a series of pharmacological manipulations and transections to show what pathways are being activated. And unfortunately, what he found is that when you stimulate at low levels of stimulation, in this case, this is intensity, this is frequency, you get nothing. As you start turning it up, you actually get tachycardia, an increase in sympathetic tone. And then as you turn it up more, you get a bradycardia, which is indicating a decrease in sympathetic tone and increase in parasympathetic tone. This was done in canines. We've actually been able to recreate this work in our lab as well. This is a pig where we're stimulating for 30 seconds. And when we stimulate with an epineural cuff, at 1 milliamps, we get tachycardia. And so Ardell postulated that this is because of activation of large diameter cardiac sensory afferents. As you start turning it up at 2 to 3 milliamps, you start getting the parasympathetic efferents going to the heart, and you attenuate the tachycardia, and you get to a null point. Then as you turn it up, the parasympathetic efferents to the heart start dominating, and you start getting bradycardia instead. So this is much more complex than a lot of people appreciate. And unfortunately, we've found doing spatially selective vagus nerve stimulation, where we only stimulate a portion of the vagus near different fiber types, it's even more complex. So we recently published this work, but what we found is often you have sympathetic trunk fibers that are hitchhiking with the vagus. And if we place the electrode over the sympathetic trunk fibers directly epinaurally, we get tachycardia. If we place it away from them, and they're going to be closer to the parasympathetic efferents, we get bradycardia. So you can imagine the implications of this for non-invasive stimulation, where you're stimulating at a distance and getting all of this as a big mush. So I've done a lot of human programming, and the animal model data is actually really misleading. And the reason being is you can't stimulate at the levels you want to in humans. The truth of the matter is you activate large diameter fibers that cause muscle effects and pain, often well before you get to these small diameter fibers that you want for therapeutic effect. And there's different fibers that are responsible. So when you're stimulating invasively the cervical vagus, you're predominantly stimulating A alphas and A betas from muscles for your side effects. When you're stimulating non-invasively, you also bring in A delta nociceptors in really every square micron of tissue that create nociceptive pain. That becomes your functional limit. So they already know this is the case for vagus nerve stimulation with invasive vagus nerve stimulators. So the side effects for vagus nerve stimulators are actually very similar to the NEO, which was the carotid sinus nerve stimulation device that I was part of, because you're stimulating pathways in the very similar area. But to deal with this, they actually don't and can't turn up patients to therapeutic levels immediately. And so what you see at the bottom is the common dosing for epilepsy. And they actually start at 250 micrograms because that's the most people can tolerate without getting neck muscle activation that creates vocal changes, cough, etc. And then they leave it there for 2 weeks, and then they turn it up 250 micrograms. And then they slowly turn it up over the course of 6 to 7, 8 weeks to get to 1.5 milliamps or 1.75 milliamps, which if you look at the animal model studies is just at the cusp of barely being able to activate A delta fibers that are the afferent pathways to the brain, and B fibers, which are the parasympathetic efferent pathways to the heart and rest of the organs. So not surprisingly, we've had 3 clinical trials fail in recent years for heart failure for vagus nerve stimulators. And in each case, when they tried to measure, were we getting any heart rate effects at all, they found in the majority of the patients with the invasive stimulator they couldn't, because they were limited by these side effects mediated by easy to activate large diameter fibers. So I'm going to very quickly go over 2 other indications for VNS and invasive VNS, stroke rehabilitation and activating the anti-inflammatory reflex, and show you that the dosing is in those a little bit complicated, even though their mechanisms of action are very different. So this is great work by the Kilgard group. They've done a ton in this area where they're looking at stimulating the vagus for inducing plasticity and learning in stroke and many other conditions. And what they typically find is what they show as an inverted U curve, that as you turn up current in the rodent, you get to a point where there's a maximal effect, and then if you turn it up more, you actually start even hurting the effect. For the anti-inflammatory reflex, we're typically trying to create changes at the spleen through both afferent and efferent pathways. And this is really interesting work by Chang's group, showing that in rodents that different doses can certainly decrease significantly pro-inflammatory molecules, in this case TNF-alpha, but that in this case they're turning up the pulse width and they're causing an increase as well. This suggests for non-invasive we need to be very careful. We often say everything that goes to NTS seems to have really good effects, and we ignore the fact that NTS does a lot of things we probably don't want to have happen as well. Another critical point, and this goes to a lot of the confounds in the research I see, is this NTS pathway is involved in our fight or flight reflex, our startle reflex. It's activated by just about everything, not just vagus nerve stimulation. So this is a nice study where they do a cold pressure challenge in an fMRI. They actually just put foot in ice water, and what you see in the upper in A is the region of interest in the ventral medulla and the dorsal medulla. And you see you get clear signals of NTS-esque activation and changes in sympathetic parasympathetic tone, which is what you'd expect with any perturbation that creates a startle response. And so not surprisingly, just about stimulating any nerve, if you do it to the point where it creates a startle response, changes heart rate variability, changes blood pressure, and actually changes circulating cytokines as well, and response to LPS challenges. This is actually what you would expect by the mechanisms purported for each of these things. So now that you've seen how complicated invasive vagus nerve stimulation is, I'm going to talk a little bit about transcutaneous vagus nerve stimulation at the neck, the evidence to support direct activation of the trunk and to refute it. And I'm also going to ask, does it even matter if the phenomenology helps people? So we often forget that if we're stimulating from the surface of the skin, and we're attempting to activate A deltas and B fibers in the cervical vagus, which varies in distance but can be 2 to 4 centimeters deep in a human being, that then you have to activate every A delta and B fiber in between. And the truth of the matter is every square micron in between is actually innervated. We think of this in terms of canonical trunks. This is the stuff directly beneath an electrode. You have the great auricular nerve, which is above the muscles and goes to the ear. You have the transverse cervical nerve, which bifurcates very quickly and innervates the platysma muscle. And typically when we stimulate with non-invasive VNS, the most obvious thing is we activate that bifurcated transverse cervical nerve. We cause activation of the platysma muscle, and we cause lip curl. And that slowly increases until we get something that the patients tell us to stop. Sometimes you actually get a referred sensation of activation that goes to your ear, which is typically mediated by the great auricular nerve. Now that's just the stuff closest to the electrode. What we're seeing under SPARC with great work by Andrew Schofstall and Nikki Polloy, this is micro-CT. This is just a sample taken near the carotid sinus and how complex the innervation is. It's much more complicated than we want to believe. There's not just the canonical nerves and branches. There are fibers and fascicles without epineural going everywhere. And that makes sense because we have to innervate every square micron of tissue. And most importantly, and this is where IVNS, CVNS, and AVNS come together, is it to some extent may not matter that much. If you stimulate just the skin of the neck, you're going to be going in through C1 through C2. That does actually create activation of NTS through a pathway that goes via the spinal cord. Similarly, if you're stimulating the trigeminal nerve, you'll activate NTS. Really, it's hard to stimulate something that doesn't. So if you look at the pieces of evidence for transcutaneous cervical vagus nerve stimulation stimulating the deep fibers of the vagus, there's several points that will come up. One is this modeling study done by Merome Bixum. Merome's a friend of mine. And what they did was take their existing model, they did not validate it for this purpose, and tried to say if you're using normal electrocore parameters, do you get activated of the deep fibers of the vagus? What they found is you don't get activation of C fibers, and that you could maybe get some activation of A deltas and B fibers, and you get A beta activation. What's important if you look at figure C is you activate everything in between as well. And it's missing every other nerve in between. So the next piece of evidence is somatosensory evoked potentials. They'll stimulate the cervical vagus, they'll move it to the sternocleidomastoid, they might compare it to the auricular vagus, and then they'll look at evoked potentials in the brain. And the idea being that if you activate at these distal points, they will propagate through multiple synapses, and you'll see a delay in the response in the brain. Now, there have been a lot of confounds in these studies historically because you also get muscle activation. And if you're not doing a paralytic, you can get some false impression of a somatosensory evoked signal. But this is a study done by NONIS where they were comparing cervical and auricular in evoked response. And they're showing those are somewhat similar in terms of the evoked response. And then they're comparing cervical vagus to flipping it and putting it over the sternocleidomastoid, and they see something that they say is different. Now, this is not very compelling to me to prove you're activating the deep cervical vagus, because I'd expect the same response if you were activating the great auricular just under the electrode. You would still see synaptic delays mediated through the spinal cord. It might be slightly different, but this is not definitive evidence. And if you also look at these P1 and N1 peaks, in terms of the delays occurring after the stimulation, a lot of times the delays are really quick, surprisingly quick. But still, what's interesting in A on the right, they're looking at the proportion of subjects they saw a response in at different voltages for cervical vagus nerve stimulation. And what you're seeing is, although it's not statistically significant, another thing that looks a bit like an inverted U-curve, which is really interesting to me. Now, here's another paper where they do fMRI to look at activation in the brain. In our hands, fMRI isn't a great measure for anything that changes autonomic tone, because if you induce any startle response, you'll activate NTS like a Christmas tree. So you have to be very careful with your control, but they do show some activation in NTS. And often what they're comparing is activation in electrocore in the normal mode versus putting it on the sternocleidomastoid, which is more of a spinal pathway, and doing a difference in what they see activated as well. Now, these are the reasons I don't find that data definitive. This is a study we just did with the Worrell group, and this is why a lot of people who do implantables are skeptical, is because if you're just a little bit of a distance from the vagus, the fall off is a lot. So in this case, we were putting a stent electrode in the IJV, which touches the vagus, and comparing it to directly stimulating the vagus. And so typically what we saw is if we stimulated in a monopolar fashion, the contact closest to the vagus, this was the dose response curve for the large diameter fibers that cause the muscle response that you don't want. If you directly stimulated the vagus not through the IJV with the same electrode, the threshold was about 150 micrograms. It's about 750, just having a couple hundred microns of tissue in between. If you do it in a bipolar configuration, so in B, so some of the current is shorting, it's actually about 1.5 milliamps to activate the largest diameter fibers, which is about 10x the difference of directly putting this on. And what C is really interesting, you'll notice that now the bipole is spaced really far, it acts more like a monopole, and the response is much more like a monopolar response that you see in A as well. So we've also recently published work where we modeled transcutaneous cervical vagus nerve stimulation, and we actually did measurements in pig cadavers to see the voltages that get to different areas of tissue as well. And in our model, we started including just the superficial sensory receptors under the skin. In this case, you have A deltas in the skin and A betas that are a little bit further away. And what we find very quickly is, one, that the red is actually for transcutaneous with a TENS patch. And what you see is the threshold for activation of the vagus A beta fibers is right at the cusp of what electrocore can do. But most importantly, you never get there. You activate the A deltas in the skin way before you activate A deltas in the cervical vagus. The reason there's such a variability here is we actually model A deltas not just under the electrode, but in the skin away from the electrode as well. And if you're even just looking at A betas in the skin versus A betas in the deep vagus, what you find is there's somewhere around 100-to-1 ratio that you have to turn up 100 times higher to activate A betas in the deep cervical vagus than the A betas in the skin as well. So this is more recent data. In this case, it's in the monkey, where we show you that stimulating the V3 branch of the trigeminal nerve can create very similar effects. So when the nice thing about the V3 branch of the trigeminal nerve is it comes out of foramen that's very superficial. You can get an electrode just over the trunk. In the middle, you're seeing periods of stimulation where, depending on the dose, we can create repeatable tachycardia or repeatable bradycardia. It's modest, similar to AVNS. And when we do so, we essentially confound MRI measurements. MRI measurements are based off of neurovascular coupling, and unfortunately, if you change blood flow to the brain centrally, it's a big confound of the measurement in general, but yes, we do see activation in the brainstem. Then we often see this broad negative bold when we create tachycardia because you're changing blood flow broadly to the brain. I think most importantly, we don't want to be stimulating all the A deltas and B fibers all the way to the vagus as well. So this is the neuroanatomy of the neck. And typically, we don't even get the referred sensation to the ear. We get the activation of the platysma muscle. What's a really cool study that was done by Galvani, they're stimulating this, the artery going into the spleen to get the C fibers that are superficial. And what they show in 2 different studies is when they stimulate the C fibers that they're intending to change input to the spleen, they also get constriction of the artery. To some extent, you have to, because those C fibers also innervate the smooth muscle of the artery. That's the sympathetic input and causes it to constrict. So you can actually infer a lot about where you're activating, even though you can't see the electric field, by knowing the neuroanatomy and predicting what you should be activating. If you were activating the deep cervical vagus, you would be activating a ton of different nerves that are there that you probably don't want to activate, including the preganglionic fibers of the sympathetic trunk. You'd probably be getting the phrenic nerve and causing diaphragmatic contractions, and you'd be getting a lot of things like cough and more traditional IVNS side effects. So why you might not even care about this? Activating the cervical vagus trunk is a bit of a semantic gotcha question. One, invasive vagus nerve stimulation has very little proof they're engaging the fibers they want to. Second, it's non-invasive, and invasive isn't too specific right now either. More importantly, if we get rid of all these trunks, there's vagal and sympathetic projections to the thyroid, the lymph node, all the major superficial vasculature just under the skin. That's much closer to the electrode. Activation of the superficial cervical plexus nerves has been shown to light up NTS anyways. And there's a lot of phenomenology show that we're helping people. So do we care? Now, because I'm short on time, I'm going to spend very little time on auricular vagus nerve stimulation. Some of the points for TCVNS are relevant to this, some of them are not. Most importantly, we and others have done a review paper of auricular vagus nerve stimulation. And one of the things that gets conflated is the auricular vagus branch comes off the vagus, but it actually bifurcates and has many cross connections. By the time it comes to the ear, it's going to be a very limited subset of vagal fibers. And predominantly what we're trying to stimulate is superficial sensory receptors in the skin that are innervated by the auricular vagus, in the tragus and in the symbiconcha. Note there's a consensus with AVNS that they know they're only activating cutaneous A beta fibers. And yes, these are, some of them are definitely vagal. And because they're very close to the electrode, you're stimulating them. You're probably also getting some of the trigeminal nerve and maybe even a little bit of spinal. Now, we did a review paper on AVNS where we looked at 41 pre-register studied for AVNS. And even though they know they're stimulating the sensory receptors in the skin, they're not stimulating the auricular vagus trunk, which is very small and very distant at that point. It's bifurcated a ton of times. And they know they're limited by pain caused by A delta nociceptors. They tend to stimulate in the exact same frequency, pulse width, and amplitude as invasive cervical vagus nerve stimulation. The other thing that we noted is that there's a lot of risk of bias in these studies. Of the studies that we looked at, only 2 had what we would call low risk of bias when we evaluated via the Cochrane scale. That's totally understandable. These are relatively early stage studies. We're learning a lot as we go, but I encourage you to look at the paper in terms of suggestions that we make for reporting to get a higher quality of evidence for AVNS. But we did see that there's evidence that if you crank it up, you can get some heart rate changes, just like we did with the trigeminal. We did see some evidence that there is some changes in inflammatory markers. There's some changes in epilepsy, and there's some changes in pain. So this is promising data, and I have no doubt that they're stimulating some vagus input as well. But the truth of the matter is we don't know the mechanisms for most of these therapies, so we don't know what vagus input, and if we need to get to A deltas and B fibers and C fibers, and at the level of the ear, these encode very different things. The other thing that's very important is we've known for a while that we get the Arnold's reflex. We'll mechanically manipulate the ear. About 1 in 20 people will get cough. They'll get large blood pressure changes or heart rate changes as well. This may be a vestigial and a sensory confusion thing with the traditional vagus. So it's interesting. I grabbed one study because I found it really interesting in terms of AVNS. This is for pain, where they compare sham to active. And we saw this a lot across AVNS studies, where credit to them, they show each individual. But if you look at this closely, there's only a large response in this one subject. There's 2 others where there's a slight response. The rest, there's no response. And interestingly, in the sham, most of them go up in pain, not down. So there's a lot of commonality, maybe more than there should be, between invasive and non-invasive. None of us are mimicking the natural sensory activity. The sensory receptors for each of these modalities are probably different with different coding. Side effects and knowledge of the anatomy are your friends. They let you infer the electric field you cannot see, and the side effect anatomy is different for each of those. TAVNS and TCVNS appear to be drawing from outdated and simplistic IVNS paradigms. We now know IVNS is much more complex. We need to be thinking about, because we're seeing some nice phenomenological effects across all modalities, how could activating only large diameter fibers cause these effects? Maybe for non-invasive, is stimulating the cervical, spinal, trigeminal, and vagal pathways together an advantage that we should optimize to? We're all going through NTS. We really need to think about sympatholytics and beta blockers in the human studies. They're big confounds. Sympatholytics act on the same brainstem nuclei. And if you're doing heart rate variability, if someone's on a beta blocker, you've cramped heart rate. Our shams, we need to titrate sham to equivalent startle response. We're intervening at one node in a system. We really need to think about how the other nodes might adapt, look at plasticity and some dynamic systems theory. We all need to improve our standards for reporting. We need to clearly state and address each confound in every paper and say how we addressed it in the experimental design, or at least include it as a limitation. We need to recognize that our studies are pretty low N. These are highly contaminable and subjective metrics in many cases, and we need to account for that. And reporting current pulse width and frequency isn't enough. People are stimulating in 100 different ways. You have to report the electrode dimensions and spacing so we can compare across studies regardless of your stimulation modality. And finally, ending on a positive note. This stuff works in small and large animal models, and there's some compelling phenomenology in some patients. We need to figure this out specifically about limiting side effects so we get more of the activation we want. SPARC's doing a great job of getting us the tools to do this. Knowing the superficial anatomy will make non-invasive much better. When we realize we aren't stimulating deep very effectively, we can optimize stimulating the shallow stuff to make a difference. Advanced waveforms actually show some promise for reversing the order of recruitment. I want to call out old work by Strujix, some recent work by Zanos and Ken Yoshida's group. Spatially selective stimulation has promise as well. You should look at some stuff from Holders and Zanos. We've done some stuff, but I think we're going to get over this hump of activating the fibers we don't want and being able to target the ones we want more effectively. So these are my acknowledgments. Thank you for your time. You can have more conversations like this with me on LinkedIn.